I think, the first two cranial nerves, right? So, were there any questions about that? Okay, so we're going to start today with the third, the fourth, and the sixth cranial nerve. We grouped those together because the third, the fourth, and the sixth cranial nerves all have to do with intraocular motion. Okay, and so there's various ways to kind of look at this cranial nerve thing. One is where the nerves originate, and so we talked earlier about where the cranial nerves leave, how they get out of the cranial space. There's another way to look at the cranial nerves, and that is their origin. So like the first and second cranial nerves are kind of special. Basically the optic nerve and the olfactory nerve, they're kind of different. They're kind of in the frontal part of the brain. Cranial nerves 3 and 4 originate from the mesencephalon. So just in terms of their origin, a lot of times it's easy to think about those two just because they both come from the mesencephalon. The fourth cranial nerve is the only nerve, the only cranial nerve that actually originates from the dorsal aspect of the brainstem. All of the other cranial nerves come off from the ventral aspect. So that makes the fourth cranial nerve a little bit more vulnerable to trauma. The fifth cranial nerve is the only cranial nerve that originates from the pons, so we kind of think of it kind of special, just by itself. And then 6, 7, and 8 come out of the pontomedullary junction. So a lot of times diseases that are kind of in that area in the pontomedullary junction will affect 6, 7, and 8 kind of together. So that's what we think of those as kind of a constellation of syndromes. And then 9, 10, and 11 actually originate from the velum, so they're kind of lower down cranial nerves. And then the 12th cranial nerve actually originates from the upper cervical spine. So just in terms of origin, that's kind of one way to look at the cranial nerves. So what I'm going to do right now is I'm going to group the cranial nerves by function. And so I know, I was back in the back of the room just a minute ago. I know people in the back can't really see the slide very well, but it is on the canvas. But anyway, we think of the third, the oculomotor, the fourth, the trochlear, and the sixth cranial nerve kind of together in terms of function because they're all involved with extraocular motor function, amongst other things. And so that's kind of a way to kind of group those cranial nerves. And so what I'm going to do today is I'm going to draw a picture of if you're looking at someone. So here's the right eye, and here is the left eye. Okay. We think of, I'm going to show you a little trick. This is a really cool trick. I'm just going to kind of show a diagram here which kind of shows how these cranial nerves make the eyes move. So if you're looking at a patient, this is as you're looking at the patient's face. I'm going to draw a diagram here that looks like this. Okay? And so this diagram kind of shows the direction that the eyes move. And so the muscle that moves the eye inward, okay, that's called abduction, abduction. The muscle that moves the eye in is called the medial rectus muscle. The muscle that moves the eye out is called the lateral rectus muscle. When the eye is abducted, the muscle that moves the eye up is the superior rectus, and the inferior rectus will move the eye down when the eye is abducted. That's a little bit tricky here because the inferior oblique moves the eye up when the eye is turned in, and the superior oblique moves the eye down. So it's a little bit tricky there. Inferior oblique, the superior rectus, and the inferior rectus. Okay, those are the way that those muscles, and of course the muscles attach, here to the eye. you're making the right eye and the left eye move. So that's what we call a diagram of the way that the eye ducts. Basically, it's the diagram of the eye movement. And so it turns out that the third cranial nerve goes to all of the muscles except the superior oblique and the lateral rectus. Okay? So, you know, the third cranial nerve innervates all of the eye muscles with the exception of the superior oblique and the lateral rectus muscle. So if I just put on the diagram here, the sixth cranial nerve is going to be functional here, and the sixth cranial nerve will be functioning here, and the fourth cranial nerve will be here, and likewise here. And all the other muscles are either oculomotor or the third cranial nerve. So, lateral rectus is the sixth nerve, and the superior oblique is the fourth nerve. The third cranial nerve also constricts the pupil. And accommodates the eye. And it also innervates the levator palpebris superioris. Okay, so the third cranial nerve kind of lifts the eyelid, it constricts the pupil, it produces accommodation, which allows you to see up close. Okay, and it goes to all of the cranial nerves, all of the muscles of the eye, except the superior oblique and the lateral rectus. Okay? That's all you need to know about the eye movements. And so, let me give you an example. Okay? And so, here we have, we draw these diagrams like this. Okay? And so, let's suppose that this is the way the eyes look. When you ask the patient to look to the right, this is look right, straight ahead. Okay? This is the way the eyes look pretty good so far. Okay? But now when you have the patient look to the left, let's suppose that happens. So which cranial node is not working? The sixth, but that's part of the answer. Which one, the right or the left? The left, this is the left sixth cranial nerve also. Okay? And this happens very frequently. I promise you, every single week, I will have some patient who comes in and has this kind of an eye movement disorder. Okay? And usually it's caused by diabetes. Diabetes causes little tiny lacunar infarcts, and one of the very favorite places that it likes to get is the sixth cranial nerve. Question in the back.
So would that mean vision would be the same? They just wouldn't be able to turn their eye?
Yeah, the vision's 20/20. They have perfect vision, but they have double vision. They come in and the symptom, the reason that they come in, so, you know, we divide things into symptoms and signs. Symptoms is what the patient tells you. And so the symptoms for this patient is double vision or diplopia. Diplopia. They see double when they look to the left. And the signs is what we measure here. So when we, have the patient look to the right or left, and we kind of see this eye movement disorder. And so that would, tell us very quickly when we just have them look to the right or left, if they have a sixth cranial nerve palsy there. Tells us exactly what the problem is. Okay, now do another one. So let's do another one. Here's right, straight, and left. So this is look to the right, look to the left, and this is straight. And let's suppose that this time we have eye movement or we have eye position that looks like this. Be consistent, so I don't confuse you. We're going to look over here like this. Look like this. Okay. So the defect here is look to the right. And so the problem here is obviously the eye movements are good, straight ahead. They're good when you look to the left, but when you look to the right, there's something that's not quite right with that vertical alignment. So when you're looking to the right, the left eye is higher than it should be. Okay? So what cranial nerve is involved here? Okay, this is an example of a right fourth cranial nerve palsy. Why? Because if you go back and look at that diagram that I just drew for you over here, the muscle that is going to move the left eye down when you turn to the right, okay, is the fourth cranial nerve. And so this is the left fourth. In other words, this eye is too high. The reason it's too high is because the superior oblique on the left side doesn't have enough force to move it down. Okay, so this is an example. Look at the diagram here. When the eyes are turned to the right, okay, the left eye is up too high. And the reason it's up too high is because the muscle that moves that left eye down when it's abducted is the left fourth or the superior oblique muscle. Yes?
Could it also be that the superior oblique is working normal and the inferior oblique is over working?
It could. It could. So, yeah, absolutely. That's very intuitive here. And so it turns out that actually when we do this test, we have to actually do 3 more things, which is not important for this class, and I'm not going to quiz you on it. You're absolutely right. It could be that the problem is that the lateral rectus, or I'm sorry, the superior oblique, superior rectus on the right, superior rectus on the right could not be pulling the right eye up, right? So it's a balance between those two. So it's always a superior rectus and a superior oblique when you have one of these. And actually going through and figuring that out is another whole story. It'll take the rest of the class to explain that. Okay, but for this simple little diagram here, I've kind of shown you that the left eye is up too high. I told you that. And that tells you that the superior oblique, which pushes that left eye down, is not working correctly. And that usually means a fourth cranial nerve palsy on the left side. Okay, so you can go through all these puzzles, and there's a, if you want to read more about it, there's a 3-step procedure that we go through that involves head tilt and rotation in order to decide which of the superiors or inferiors is actually blank. But almost always it turns out to be the 4th cranial nerve, because if you have a 3rd cranial nerve, you'd expect some other things to not be working right. So if the 3rd cranial nerve doesn't work, what would you expect? In addition to some motor problem, you'd expect the eyelid to be droopy. In other words, you might not even be able to see the eye movements at all, because you have a ptosis. What else? You're going to have a dilated pupil, right? Because the 3rd nerve constricts the pupil, so if you don't have the 3rd nerve working, you get a big old dilated pupil. Plus, then you get extraocular motor dysfunction that involves all of the other muscles except for the lateral rectus and the superior oblique. Okay? All right, that's enough for you. So that kind of knocks off the 3rd, the 4th, and the 6th. Now the 5th nerve is called the trigeminal nerve. The reason it's a trigeminal nerve is because it has 3 big branches. It has a superior ophthalmic branch, it has a middle branch, which is called the maxillary branch, and it has a 3rd division, which is the mandibular branch. And the reason that those are named such is that they go to that part of your face. So the 1st division of the 5th cranial nerve goes to your forehead and your eye. The 2nd division of the 5th cranial nerve goes to the maxillary area of your face. And then the 3rd division of the 5th cranial nerve goes to your mandible, to your jaw. So it's sensory. The 5th cranial nerve provides the sensory input for the face. In addition, the 5th cranial nerve goes to the big muscles, the chewing muscles, the masticator muscles that allow you to chew. So the 5th nerve gives you all the chewing. You bite something, that's the 5th cranial nerve.
Dr. Islander?
Yeah.
No question.
Yeah.
So going back to the eyes and the muscles that move them, so when they move to the side, do all 3 of them engage? The lateral, or is the rectus, the oblique, and the...
So, when you're looking horizontal gaze, you're looking horizontally. It's a pair, the 2 that give you conjugate eye movement is always a combination of a lateral rectus and a medial rectus. So just pure horizontal movement is a coordination between the lateral rectus and the medial rectus. So when you track something and you read, you move your eyes horizontally, okay, it's always coordinated firing of a medial rectus and a lateral rectus that allows you to do that. Okay, now the elevation and depression is always accomplished by a combination of medial rectus and superior and inferior obliques. And the field of action is such that the obliques are more important when the eye's turned in, the eye's adducted, as opposed to when it's abducted, when it's turned out.
So when, like, say the eyes are in, would the obliques be relaxed, or would they be...
Well, ordinarily, they're all firing all the time, but they're just coordinated. And so ordinarily, you have a very smooth pursuit that just makes your eyes stay perfectly level. So it's a coordination between the superior and inferior oblique when it's turned in, and the superior and inferior rectus when it's turned out. Okay? It turns out that this tracking, since you brought this up, okay, the tracking is actually accomplished in your brainstem with the coordination between the 3rd cranial nerve nucleus and the 6th cranial nerve nucleus. Okay? And so it turns out that actually that's quite complicated. You won't ever have to think about it. But conjugate eye movement is extremely coordinated between those 2 cranial nerve nuclei, which are separated by a distance. The 3rd cranial nerve nucleus is called the Edinger-Westphal nucleus. It's in the mesencephalon. Okay? And then the 6th cranial nerve nucleus is all the way down at the punctomedullary junction. there's a whole slew of very interesting syndromes which affect conjugate eye movement. That's not a topic for this class. So let's if there are any questions here. So we got the fifth nerve. It's sensory to the face, and is your chewing muscles. And we kind of think of it as separate because it comes from the pons. And then the seventh and the eighth nerve, we think of them kind of together because they're both going through the internal auditory canal, the internal auditory meatus. The seventh nerve goes to give you the muscles of facial expression. This is different from chewing. When you have somebody that smiles, or a good way to test the seventh nerve is just show me your teeth. When you do like this, you have to use the muscles in your face. Show me your teeth. And that's the muscles in your face. These are the muscles of face or smile. Or another way is to say close your eye, because it also goes to the muscles that close your eye. So it goes to the orbicularis muscle, which squeezes your eye shut. So the seventh nerve goes to the muscles of facial expression. So that's why it's called the facial nerve. The other thing that the facial nerve does is it goes to the anterior part of your tongue, to a little branch that actually goes to the inner part of the ear called the chorda tympani, which gives you taste on the anterior part of the tongue. So the seventh nerve is facial expression plus taste on the anterior part of your tongue, plus the seventh nerve also goes to the lacrimal gland and it makes you tear. Okay, so it goes to the lacrimal gland that allows you to make tears. So there are several things that the facial nerve actually does. Now, one of the diseases that is quite common that affects the facial nerve is a disease which is called Bell's palsy. And so for the seventh nerve, there's a disease called Bell's palsy, which is a kind of a temporary, usually it's a temporary defect in the seventh cranial nerve function. Does anybody know somebody had a Bell's palsy? Come across someone? Yeah, back in the back.
Yeah.
What was the story?
My mom had a stroke and had Bell's palsy for a little while after, but it's better now.
Yeah, usually gets better, but it can affect, a lot of times it affects, folks your age. So you don't have to be old to get Bell's palsy. Usually it happens after you have kind of a viral illness, and it's kind of like, Keanu Gray, you just think you're fine, and all of a sudden you can't close your mouth, you can't smile, you can't close your eye. Actually, not being able to close your eyes is a real problem because that's what protects your eye. So basically you go around with one eye that's kind of open all the time. And so, it presents a lot of problems, ophthalmologic problems, because of the lack of being able to close the eye, the lack of ability to blink. But most of the time, Bell's palsy actually, you have this facial palsy, but you get better, it corrects itself. One of the things that very commonly happens after Bell's palsy, if you have, unfortunate enough to have this, is that you get a thing called aberrant regeneration. And so it's kind of interesting, when this happens, the neurons quit signaling. And so you kind of have it in the middle of the neuron between the destination and the cell body, which is in the main sport of the spinal cord. When the nerve begins to kind of regrow, when it begins to kind of rearrange and repair itself, because these are peripheral nerves. So these cranial nerves are peripheral nerves. They're outside the dura, so they'll repair themselves. Then you get what's called aberrant regeneration. And it makes for a real interesting syndrome called the syndrome of the crocodile tears. And so what happens is that the seventh nerve Also, as we'll see in a minute, goes to one of the glands that produces the saliva when you eat. And so what happens sometimes, those fibers get twisted a little bit. And so the fibers that were going to go to the gland that produces the tears actually go to the lacrimal gland when they regrow. And so every time you think about eating a big steak dinner, all of a sudden you start crying. It's called the syndrome of the crocodile tears. But anyway, that's Bell's palsy. The eighth nerve is the nerve for hearing. It's called the acoustic nerve. And basically it provides the information on balance. So it actually comes from the semicircular canals and labyrinth. So it basically gives us information about positional sense. It also is kind of the origin of our vestibulospinal tract. And most importantly, is the nerve that the auditory nerve that gives us the hearing. So basically this is the nerve that goes from the cochlea into the brainstem. 9, 10, and 11 are, as I mentioned, I kind of think about those kind of together. The glossopharyngeal, the vagus, and the spinal accessory nerves. The glossopharyngeal nerve gives you taste on the back part of your tongue. So it gives you kind of a bitter taste. So it's coming from the back part of your tongue, and it actually goes to some of the muscles in the back part of your mouth and your palate. The vagus nerve is a nerve which is widely distributed. The vagus nerve we think of as being primarily our parasympathetic system. And so the vagus nerve is going to go to your heart, your lungs, your abdomen, all your other organs, your abdomen. And so the vagus nerve is your nerve that is secreting the acetylcholine. And so the vagus nerve controls heart rate, it controls the size of your bronchi, it controls your bladder, it controls a lot of different things. It's a very important nerve. And then the 11th, the spinal accessory nerve, goes to the muscles, the sternocleidomastoid muscles. So the way we test this is the ability for you to rotate your head. And so if you can rotate your head from right to left, you can test the amount of force you can generate, then the spinal accessory nerve is probably working. And then finally, the 12th cranial nerve, the hypoglossal nerve, is the nerve that makes you stick your tongue out. So if I stick my tongue out, that's the hypoglossal nerve. Now if you have a defect, if something happens on one side, you have, say, a right hypoglossal nerve palsy, what happens is, because you now can't push as hard on that side when you have the defect, the tongue will deviate to that side. So like a right hypoglossal nerve palsy, I can't really do it very well, but the tongue's going to go over to the right side, and that's how you can tell if you have a hypoglossal nerve palsy. You can't stick your tongue out. Yes?
I was going to ask on the last one on the accessory nerve. This is kind of just, I was trying to think of applications, but would it apply to, like, if you get a cricket neck kind of thing? Is that exhibit? Like, you pinch your nerve and you can't move your neck very well or something?
I think that's probably more has to do with kind of the vertebra in the neck, probably more than the spinal accessory. If you have a spinal accessory, you just can't move, you just don't have that force to move the head all the way to that side. But it's not something that's kind of transient. If you have a palsy, it's going to be kind of permanent. Yeah.
So people that control their tongue, do they have like better nerves?
Yeah, I mean, some people, you can curl your tongue, you can do all kinds of crazy things. So yeah, you probably have a little better, nerve control. And actually, everybody's different. It's not just tongue curlers and non-tongue curlers. Some can do tricks, with their tongue too. A lot of, kind of like being ambidextrous, right? All right, so anyway, it turns out that these, so that some of these have some kind of other special functions. So I mentioned to you the 7th nerve, it goes to the lacrimal gland, that's the gland that tears, but it also goes to the submandibular and sublingual glands. These are glands that produce saliva. Okay? And so when you get that aberrant degeneration, so you're getting, the crossover between the fibers that should be going to the lacrimal gland, and those fibers that go to your mouth that produce the saliva. The other big gland in your mouth, which is located actually right on this part of your cheek, just in front of your ear, is the parotid gland. It's the gland that's involved in mumps. If you ever had mumps, when the side of your face swells up. And so the ninth nerve innervates. It has a special visceral afferent, that goes to the parotid gland that allows you to secrete, for digesting your food. The vagus nerve also has some very special function. I just wanted to make sure that I mentioned this. So in addition to going to the heart, the lungs, and the abdomen, and all in your gut and other things, so it also has a branch that's called the superior-laryngeal nerve, which goes to the cricothyroid muscle, which is the little muscle right here, kind of in the upper part of your neck. And more importantly, it goes to what's called the recurrent laryngeal nerve. And so this is the vagus nerve going to the recurrent laryngeal nerve, which innervates your vocal cords. Okay? And the reason this is important is because this branch of the vagus nerve actually comes back up from the upper part of your thorax and then goes through the thyroid gland before it actually goes to your vocal cords. And so surgeons learn very quickly that this is actually one of those nerves that you really, really have to know well, because anytime you do surgery on the thyroid gland, if you're taking a thyroid adenoma or tumor, you have to be extremely careful not to injure the recurrent laryngeal nerve, which is a branch of the vagus nerve, which goes to your vocal cords that allows you to speak. And so if you have thyroid surgery, and you don't pay attention to this, one of the bad things that can happen is you lose your voice. So that's kind of an interesting one. And then I put down here one of the other kinds of special things that the spinal accessory nerve goes to is the stylopharyngeus muscle, which is one of the muscles that actually regulates the amount of sound that your ear can hear. So those are some interesting special things. The ninth nerve, additionally, so we talked about the ninth nerve going to innervate the back of the tongue and some of the pharyngeal muscles, but it goes to two other places which are really important. One is the carotid sinus, which helps to regulate your blood pressure. It's a blood pressure sensor, and so we talk about negative feedback loops. So if your carotid sinus, which is in your common carotid artery, it's sending afferent information that tells your brainstem, specifically the glossopharyngeal, the ninth nerve nucleus, what your blood pressure is, and then that then sends out signals that regulate the caliper of your blood vessels and your heart rate that helps to keep your blood pressure normal. The carotid body, which is at the bifurcation of the internal common carotid and the internal external carotid, has little sensors that measure CO2 and oxygen in your circulating blood, and then that goes to the respiratory center, which is in the upper part of your medulla, and that regulates your depth of respiration. That actually is how you set how deeply and how fast you breathe. So very nice, well-described negative feedback system that constantly monitors your CO2 primarily. So our breathing is interesting, is mostly regulated by the amount of CO2 and pH of our blood. Y'all talked about the Henderson-Hasselbalch equation somewhere? Yes, y'all heard that? Well, anyway, this is how you regulate your body pH. You keep your body pH by changing your respiratory rate. You keep it around 7.4. So basically, those are some kind of special things that your brain does that helps to maintain the homeostasis. Vagus also is important in your cough and vomiting reflex. Okay? So I showed you this diagram before, and so I put this in here again just to remind me to tell you that, so we have these cranial nerves, And these cranial nerves are just like these peripheral nerves. They regenerate, except the cranial nerves seem to go to your head and neck, whereas all of these other peripheral nerves go to your arms and legs and the rest of your body. But they function the same. They're all pretty much the way that they work is the same. So I told you also that we have basically these segmental nerves that come out, but that's not the main nerves that we know the names of, like the median, the ulnar, radial nerve, some of the nerves in our arm, for example. They're coming actually from multiple branches that have all been through the brachial plexus. So my arm and hand, when I move my hand and I feel, these are these nerves, the median, radial, and ulnar nerve, are having branches that come from C5 through C8. Multiple segmental nerves. And likewise, when I go down to my abdomen and I look at the lumbar and sacral plexus, they're making these larger nerves like the femoral nerve, the sciatic nerve, and these nerves have multiple branches, okay, that are coming off of these segmental nerves. One other kind of interesting thing here is that we haven't really talked about it yet, but we have our main trunk, the main nerves come in here. And so this would be, this is dorsal here. This is ventral. Okay? And so our sensory information is coming in here. So this is sensory. And this little branch over here is all motor. So anterior is motor, posterior sensory. To make things a little more confusing here, we have these sympathetic chains. This is our sympathetic. And nuclei. Okay, and so it turns out that we have the vagus nerve, which is parasympathetic. It's basically producing all the things that become kind of homeostatic. And then we have the sympathetic chains, which are really the adrenergic system. And these are sending out autonomic nerves in the peripheral nerves. So these get thrown into the peripheral nerves too, that are regulating things like the size of the blood vessels that help to control blood pressure and temperature. Okay, so we've got all of those kind of things that are kind of going on there. Now, I want to visit this because today we're going to start talking about some of the tracks. And so we're going to memorize, we're going to learn some of the motor and sensory tracks. One of the first ones we're going to look at is pain and temperature, how that information gets from my skin up to my brain. And we know pretty much how that works. So we know that for the body, this is going through the spinal cord. For the cranial nerves, this information is coming in primarily the fifth cranial nerve, right? So in the organization of spinal cord is very much the same for all of us. It's almost identical. And in this diagram, these blue tracks, these are all called tracks because they're all white, big white matter tracks. All of the things that are kind of labeled in blue are the things that are carrying sensory information from my body up to my brain. Everything here that's red is carrying motor information that's coming from my brain down to the muscles. Okay? And so we draw these pictures and I project it on a big screen like this, but it's important to understand that your spinal cord is about the size of a dime. So, I mean, these diagrams look really big, but the actual size of your spinal cord is the very largest in the cervical part of your cord, which is in the upper part of your diagram there, C5, is about the size of a quarter, and for the most of the lumbar and thoracic part of your cord, it's about the size of a dime. The other thing I mentioned to you before, but it's important to understand that all of the cell bodies are in the middle of the spinal cord, just the opposite of the brain. When you look at the brain, all of the cells are on the outside. Okay, so the gray matter is on the surface, the spinal cord, all the gray matter is on the inside, and these tracks that go up and down are all on the outside. And so, and just to kind of point out here real quickly here, all of these things are involved in proprioception. Proprioception. The main tract that carries pain and temperature is called the lateral spinal thalamic tract. So pain and temperature is going to be carried in that tract here. The corticospinal tracts, so this is called the lateral corticospinal tract. Okay, it's carrying all the information from your brain, which is going down to those motor units that tells your muscles how to move. It will also, pick up all of these other things. You'll know exactly what they are, but we have a unconscious proprioception. And so these, really, I should have said conscious. We also have these big tracts, the dorsal and ventral spinal cerebellar tracts, which are for unconscious proprioception. So that's kind of gives you the organization of the kind of the spinal cord. And so we can make these diagrams to kind of show, again, not where specific nerves go, but where the segmental innervation kind of goes, and kind of a good, couple of kind of good, landmarks are your belly button, which, is primarily getting, innervation from around maybe T10 segmental level. Your genitalia are coming really from the sacral spinal nerves. And the sacrum also innervates the back of your legs and your buttocks. Kind of shows you the lower part where it's kind of being innervated. C, your upper extremity primarily is coming from C8 through C5. And again, the back part of your head gets some cervical nerve innervation, but your face is going to be the trigeminal nerve. So we're going to, just a minute, look at some real brains. And it turns out that there are certain kind of features that are very important that we recognize, and neurosurgeons recognize, because they are very highly correlated with structure and function. And so some of the more important things that you should recognize on a gross brain are the lateral fissure, also Sylvian fissure, which separates the parietal and frontal lobes from the temporal lobe. And then the central sulcus, central fissure, which separates what's called the precentral gyrus. So I'm going to label this here, right here. Turns out that this is all motor. So precentral, here's the central sulcus or fissure here. That's all motor.